was. And again, I'm gonna give a whole talk just on sodium, which should put everybody to sleep. But this is sort of a little teaser of it. These are the parameters. This is the first treatment dose of hypertonic saline, and this is the second treatment dose of hypertonic saline. This is arterial blood pressure, CPP, ICP, and some other measures of compliance and other measures of cerebrovascular resistance. Let's just focus on blood pressure, CPP, and ICP. So the maximal effects of the blood pressure in terms of minutes was time to maximum effect was 20 minutes in terms of how long it took in this study to get the blood pressure up. The maximum time to see changes in CPP was 28 minutes. The reason why CPP took a little longer is because it took a little longer for ICP to go down. And the maximum effect of ICP, time to maximum effects, was 60 minutes. So you'll certainly see decreases in ICP in less than 60 minutes, but they hit their peak at about 60 minutes. And they last for about 139 minutes or 140 minutes. So if you want to know the timeline, that's what it is. So if you ever ask that question again, then you can know. I would have been happy to have shared this information with you had I known that you would have been quizzed. We knew it a long time ago. Hypernatremia, I'll probably end with just one or two more slides. So sodium, low sodium is bad. High sodium is bad as well. So where's the sweet spot in a patient? Well, we don't really know exactly what the sweet spot is in any individual patient. However, you know that this is a paper published by Mike Dieringer a few years ago in the Neurological Care Journal. And what they looked at is hypernatremia in the neurologic care unit, how high is too high. And this is a graph of the number of patients, the sodium level, and ICU mortality. Okay, and you see that in terms of sodium of less than 151, mortality is down here, around 10 or 12%. This is all comers in the neuro-ICU. This is not just subarachnoid hemorrhage. Wendy's actually doing a big project right now looking at sodium in subarachnoid hemorrhage patients, and we'll gain a lot of data from that. But this is all acute brain injury patients. But if you look at greater than 160, you can see that the mortality is upwards of 52% or so. So you'll see our orders, what do they say, is hold sodium or hold hypertonic saline for what? Exactly. So that's why that number is chosen. So in general, I mean, if you're wondering why specific numbers are chosen on our protocols, hopefully there's some reason for it. And if there's not, you know, a literature to back that up, then there's some clinical experience to back that up. So, you know, in the absence of evidence-based medicine, it's anecdotal, good experiential practice. So let's just finish up on hypertonic saline a little bit of what does it do. Hypertonic saline, the systemic effects is it results in a diuresis as a consequence of salt. So hypertonic saline, unlike mannitol, which is why we use hypertonic saline more commonly now, and we've done it for almost a decade, than mannitol, is that it actually promotes its own clearance. What you want is you want first pass in general, right? So you want that strong osmotic agent in the plasma to draw water out of the brain and decrease ICP. That's what you want. But you don't want that salt to stay around the body, because you want to do it again in 4 hours. Because if it stayed around, then you would have more and more salt accumulating, and then you'd have sodium of 160, 170, 180, 190. Now that can happen anyway, obviously, as you know, but it doesn't happen nearly as much as you'd expect, and the reason for that is the kidneys take care of that. So it's whatever goes in, goes out. It increases GFR. It decreases sodium absorption. It reduces free water renal clearance. From a heart perspective, it increases cardiac output because it's really a volume expander. And actually, hypertonic saline is becoming more and more common in trauma bays. So instead of giving only lactated ringers or crystalloid boluses in somebody in shock, traumatic shock, when they're losing a lot of blood, they certainly give them back blood, but they give them back lots and lots of hypertonic saline because it really will increase cardiac output significantly. It does affect hemodilution in many ways, but it decreases platelet aggregation, and it actually decreases the viscosity really at the membrane, the vascular membrane. So it may have some other effects too. It improves pulmonary exchange because, again, for the same reason is it pulls water out of the lungs, and it's almost like a diuretic in that sense. And it decreases the pulmonary arterial tone. So it has a lot of positive effects on the kidneys, on the heart, on the circulation, and on the lungs. Too much of anything is bad. So again, you've got to watch the store as you're doing this. So the adverse effects is that if you have an abrupt change in serum osmolarity, either high or low, can lead to seizures and coma, obviously. There have been some reports of subdural hematomas and ICHs in children with abrupt osmolarity shifts by peeling the brain away from the skull. You can have some significant rebound through edema and CPM, which is why when we start bringing sodium down, we do it ever so slowly and gingerly. So hypertonic saline, is a wonderful weapon, but when you stop doing it, it's a very slow march down. You can send someone into cardiac dysfunction, congestive heart failure. There can be a lot of metabolic problems as well, but not as many as mannitol. So mannitol, you frequently get severe hyperkalemia and a hyperchloremic metabolic acidosis, which you do not get nearly as much with hypertonic saline. You can get a coagulopathy, you can get increased bleeding issues, and certainly locally you can get severe phlebitis at the site, which is why you need to always give it centrally. You can never give hypertonic saline at the 23% concentration peripherally. I think it's 8:30, so let me stop there, and the last time we'll finish up the hemodilution and other kinds of things. Any questions before we stop? Okay, well, thanks, guys.